Hi, I'm Dr. Wes Ely from Nashville, Tennessee, and it's a privilege to present today with Dr. Brenda Punn. Both of us are from the Critical Illness, Brain Dysfunction, and Survivorship Center at Vanderbilt University, and we conducted a study called the COVID-D study, which we'll be presenting original data from today with Rafael Bodenas and Gabriel Eras from Spain, and many other investigators from around the world. We would like to disclose the project was funded by the National Institute of Health and the Veterans Administration, federal funding agencies in the United States, and disclose an unrelated research project and CME presentations we've done in the past, which were sponsored by the companies Pfizer and Orion, which have nothing to do with today's presentation. Historically, over the past 15 years, from 2000 to 2015, the rates of delirium in critically ill patients were very consistently between 60 and 80%. In the past 5 years, with the advent and the increasing compliance of the ABCDEF bundle, the SCCM's ICU Liberation Collaborative, we've seen a consistent drop in delirium rates from those historic 60 to 80% down to 45 to 50%. Very encouraging 30% drop in delirium. Unfortunately, early reports from the COVID pandemic have shown that delirium has bounced back up into the 80 percentile range, and the benzodiazepine use has skyrocketed up into well over 80% for the average patient, according to the references you see here by Helms and colleagues in the New England Journal in Critical Care. In order to make it a bit easier for you and all of us to remember the causes of delirium in COVID, and also to express how frustrated we are with effing COVID, we made up this mnemonic called F-COVID to cover these 6 causes of COVID-related delirium. 3 of them are related to pathophysiology: clotting problems, oxygenation issues, and the virus itself. The other 3 are modifiable and related to the environment, such as family visitation or isolation, the immobilization that our patients are so disastrously experiencing through the receipt of prolonged episodes of benzodiazepine drips or deep propofol sedation, etc. So remember F-COVID when you're at your bedside with your sick patients. In order to think about what to do about F-COVID, you could draw on the Dr. Dre, the famous rapper, and this adjusted Dr. Dre mnemonic will help you figure out what to do when your patient is diagnosed with COVID using a validated tool like the CAM-ICU or the intensive care delirium screening checklist. Think first about disease remediation, things like sepsis, COVID clotting, CHF or COPD. Then drug removal. Every day for every patient, conduct an SAT and an SBT, spontaneous awakening trials, spontaneous breathing trials, and try to avoid very deliriogenic drugs like GABAergics, benzodiazepines, or prolonged use of propofol. And then, of course, we need to focus on non-pharmacological factors like the environment, mobilization, sleep, day-night cycles, hearing aids, glasses, noise reduction, and then, of course, very important in the pandemic, virtual or inpatient family visitation to avoid this sense of isolation and fear that our patients experience. Now I would like to turn over the presentation to Dr. Brenda Punn, a doctor of nursing practice from our SIBS Center, and encourage you all to remember to come to our website, www.icudelirium.org. That's icudelirium.org if you want any further educational materials, which are free for downloading to anyone who needs them. Dr. Punn, it's all yours.
Thank you, Dr. Ely. I'm going to unpack a little bit of the data from our COVID-D international cohort. This was a multi-center retrospective study of a little over 2,000 ICU patients that were adults that were COVID positive from 69 sites covering 14 countries, North America, Europe, North Africa, and South America. We collected data with our prospective delirium and coma assessments, demographic data, respiratory support, management strategies, and hospital course. And we used a multivariable regression to help identify what are the delirium risk factors and predictors of the amount of time the patients have that are alive without this acute brain dysfunction, delirium, and coma. In this next slide, we see that a little picture of what the patients were like. We had 2,088 patients included in the final analysis. Their median age was 64. Their simplified acute physiology score, their SAP score, was 40. 88% of them were invasively mechanically ventilated at some point during their ICU stay. And then we see the prevalence of their acute brain dysfunction. A whopping 81% of these patients at some point in their ICU stay were comatose for a median of 10 days, greater than a week, almost a week and a half. And then they were delirious. 55% of the patients were delirious at some point for a median of 3 days. So we see the combined prevalence there of 2 weeks, which is really shown well on this graph. If you look at the blue lines, these dark blue lines, bars are comatose, and then the red is delirium. And you can see on day one, for the 21 days that we followed the patients, that 60% of patients, a little over 60% in that first few days, are comatose, and that continues well over 40% into the second week of their ICU stay. And in that second week, we see the delirium prevalence continue to rise there. And this just shows that there's extreme acute brain dysfunction, either comatose or delirium, in those first 2 weeks in the ICU. Most of our patients were discharged, either died or discharged by day 14. The median length of stay in the ICU was 14. And you can see during that 2 weeks, a large majority of them spent time in either coma or delirium. And in our next slide, we wanted to understand what are the risk factors that are associated, the known risk factors that we've known about, and what's their prevalence in this particular population for the COVID-19 patients. So we really dove in and looked at sedative use while the patients were on invasive mechanical ventilation. So in our cohort of 2,088 patients, 64% of these patients had continuous infusion of benzodiazepines for a median of 7 days, 1 week. Similarly, with propofol, 71% had propofol for a median of 7 days. And then dexmedetomidine was our third most popular sedative use, and that was 44% for a median of 4 days. Then we wanted to understand, we looked at the various elements of that ABCDEF bundle that Dr. Ely alluded to, and we specifically wanted to look at the ones associated with lighter sedation, how to lighten sedation, such as spontaneous awakening trials, SATs, and how to get off the vent, the spontaneous breathing trials. We had over 20,000 days of patient data, and of those 20,000 days, only 24%, less than a quarter of the days that the patients were on sedatives, did they have an awakening trial. Similarly, 23% of the days that patients were on invasive mechanical ventilation, did they have a breathing trial. We also wanted to look, knowing that during this pandemic, nearly every single one of our hospitals dramatically limited their visitation policies. And what we found was only 17% of the days, remember that's over 20,000 days, only 17% of those days had a family visit, either in person or virtual only. And then we wanted to look in the next slide at the multivariable model of how those risk factors, and you can see on the slide a slew of others, how those risk factors impacted the odds of developing delirium the next day. We've bolded the ones here that were statistically significant. So you can see that there are some that are listed here that really are non-modifiable. So not shown here is if you were on the day previous, if you were comatose or delirium, you have a higher odds of being delirious the next day or in a coma the next day. And also other non-modifiables, your age, severity of illness, other markers of severity of illness, like your ventilation type and vasopressor use. Those things were statistically significant for increasing your odds of delirium. But the ones that I really want to highlight down here are those modifiable risk factors that are also in contrast to the recommendations that we have. So if your choice of sedative was a benzodiazepine versus any other choice or no choice at all, you were dramatically more likely to develop delirium the next day. And if you had family or friends that were present, you had a lower odds of delirium development the next day. And these just show that these are our strongest predictors of these modifiable risk factors here for developing, for having the odds of delirium the next day. And in conclusion here, if we think about what we've discussed is that delirium and coma are epidemic within this pandemic. That it's really, we like to say, a delirium factory, that all the wrong things are in place for these patients to affect the patient's acute brain dysfunction. And it's often, as we just showed, prolonged in this patient population. The doubling of the duration of brain dysfunction from any of our prior cohorts that we've been involved in, from that were less than a week to 2 weeks in this in this particular patient population. And this really sets these patients up for big problems as when they leave the ICU and they're discharged for long-term cognitive outcomes and other sequelae associated with that. What we saw in our study was that the two strongest predictors of this delirium were benzodiazepine infusions and family visitation. And what we can see is if we use that ABCDEF bundle, and largely were included in that Dr. Dre mnemonic that Dr. Ely shared earlier, when we think of those interventions in that bundle, we know from other studies that they decrease length of stay, they decrease the duration of coma and delirium. And we think that deploying those will also improve COVID-19 outcomes as well, including survival. So when we think of these COVID-19 patients, let's not go backwards to the heavy sedation, prolonged heavy sedation of our patients and lack of family visitation at the bedside, but move forward to maintain our dedication to providing evidence-based care that we know work. And we can see that this dramatically benefits these patients as well. Thank you so much.